Well, good morning, everybody. Thank you so much for being here this morning. Welcome back to Georgia Heart Grand Rounds after a long summer break. This program is brought to you by Georgia Heart Institute. The planners and speaker have disclosed no relevant financial relationships with commercial interests. I'm pleased to share that today's event has been awarded credit for physicians and radiology technicians. If you haven't yet, please make sure that you sign in at the front so that we can track your attendance for your credit. And now it is my pleasure to invite Dr. Egelum to introduce our guest speaker.
Hey, good morning, everyone. I want to take this opportunity to introduce our speaker, Dr. Brett Heimlich. He is actually a Georgia native. He's from Alpharetta, Georgia, and actually attended University of Georgia and completed his MD and PhD training at the Medical College of Georgia. He had a broader interest in endothelial function among sickle cell disease patients, and that was a main focus of his MD PhD. And actually did a fair amount of work in the global health space, establishing a sickle cell diagnostic clinic and treatment strategies in Malawi. So really wonderful work there. I would say after completing medical school, he went on to Vanderbilt, where he completed residency and fellowship. And just over the last year or so, joined the faculty as among the physician scientist track. His main emphasis in research and career development are really around the areas of cardiovascular complications associated with cancer treatment. Having said all of that, I've known Brett for a little while here, as I'm a Vanderbilt alum myself, and we had a great dinner yesterday. I found him to be very personable. He's a family man. He's really dedicated to his craft. So I'm really looking forward to hearing the discussions that he has on this topic related to cardiovascular disease among cancer survivors. Dr. Brett.
Thank you guys so much for having me today. It feels good to be home. It feels good to be back. And this is really a pleasure to kind of share some of the latest and greatest with what I do in the clinic, but also what I do in the research lab. And so I have nothing to disclose. Always on the lookout for something good to disclose, but maybe next time. And so today I've got a few learning objectives. I really wanted to take cardio-oncology as a whole and kind of break it down and share some of what I think are some of the newer kind of things that we're seeing in the clinic. And so the emphasis today will be on the kind of these newer strategies. Also, monitoring and follow-up for these patients is kind of a continual question in my mind about what to do with these, and so I'll share some of that. And then clonal hematopoiesis of indeterminate potential, or CHIP, is what I study in the research lab, and so that'll be the emphasis for the latter half of this talk. And so I'm aiming to land this plane around 45 minutes in, because nobody's ever been upset about a grand rounds that has gone too short. So I was preparing this talk, and this is really the first time I had given a broader talk on cardio-oncology, and I was trying to think about what would be important to share. And it's such a new field that I think that it requires a little bit of introduction. I'm going to introduce it by way of talking about a few myths that are out there. And myth number one would be that, well, if it's a cancer patient, aren't all cancer patients kind of destined for the same final location? And saying that, cancer is usually severe and a lot of cancer patients die. And, I think maybe perhaps in the past that myth had been true, but maybe now less than ever before is that so. The second myth is, you hear this a lot on the oncology side. Well, let's just get them through their cancer treatment, and then we'll talk about their cardiovascular care later. And I would contend that the time for cardiovascular care for cancer patients is now, and it's before, during, and after their treatment. And then the third myth is aren't all cardiotoxicity associated with cancer care permanent? And I think that's something that we hear a lot of times from my own partners. Is there anything really to be done for cardiotoxicities? And so those are the myths that I think that we come up against in cardio-oncology. And I'm kind of happy to say that I think most of those are actually demonstrably false. And those myths are actually from a gentleman down at Emory. His name is Anat Mandawat. And so those are not my myths, but those are ones that he's previously shared with me. But the European Society of Cardiology has come up with this definition of cardio-oncology kind of in the past few years. And really, this is the purpose is, to allow patients with cancer to really complete the cancer care that is needed to the best of their abilities. And this is, like I said, kind of across the spectrum of care, both before, during, and after. And I've got some data to kind of support those three myths that I think are busted. But this you can see is a little bit of recent data, most recently from 2022. You've got the number of patients on the y-axis, you've got years on the x-axis, and then in those colors, you've got the proportion of patients that have survived their cancer therapy. And these are the number of years out. And so as you can see, there's really an enormous growth in cancer patients that are survivors living out there. And this is really great news. This is a triumph of modern medical science and cancer care. But it brings the problem, straight, well, in my case, to me. And these are the kind of patients that I deal with, not just from a survivor standpoint, but also through various treatments. And driving this point home, this is data from the FDA, and this is looking at the proportion of approved drugs per year. In light blue, you have from last year, 2023, and from dark blue is the last 5-year average. And as you can see, oncology is by far and away the greatest, kind of offender here of number of new drugs that have come into approval in the both last year and for the last 5 years, and it will probably be so for the next 10 years. But this really is demonstrative of the challenge that we have in cardio-oncology in terms of keeping up with the various treatments out there and their relative cardiotoxicities. And I put this slide up here just because I think it's absolutely ridiculous. But here you've got, these are all of this is data from 2016 now, so this is even bigger now, but these are all of the proposed immunotherapy and immunotherapy combination drugs that are in various stages of development around the world. And so sometimes I feel like I'm standing right at the middle of this with all of these new drugs out there. And I know that it tends to be a little bit of, alphabet soup in terms of cancer therapies. But this is just to show that there's a broad and growing number of therapies out there that have various cardiovascular effects. And there's no sign of this slowing down or stopping either. And so I feel like this is a little bit job security and a little bit real world problems that we've got to address in my field. And so kind of with that background, the European Society of Cardiology always feels like they're maybe like a half step ahead of us here in the United States, came up with a really tour de force in terms of trying to set forth standard of care and their best shot at guidelines really for the world. And this was back in 2022. And this is something that I used a lot kind of in my fellowship. And I think this needs to come with a little bit of a caveat. This isn't like other guideline documents. This document has a lot of expert opinion in it, and there's not a lot of 1A recommendations. And I think that that's a reflection of where the science is and where we are in the clinic. And it relies a lot on, personal experience, and the data that we're needing, I think, is currently being generated both from the clinics and in the research labs. But this is really, I think, a theme, though, in cardio-oncology, that you're dealing with a lot of data-free zones, and that you have to not so necessarily rely on kind of hard and fast guideline rules, but rather you're kind of reliant on your clinical acumen and your clinical reasoning abilities, which makes it an exciting place to be and to work and to think on the daily. So perhaps you might have seen something like this before, but we kind of tend to think of, or at least I tend to think of cardio-oncology a little bit like this iceberg analogy. You've got kind of up here in everybody's consciousness, you've got radiation, so direct radiation, to the chest, anthracyclines, you got metabolites, these are old drugs, 5-FU, and then the HER2 targeted therapies like trastuzumab. I think this is, at least when I entered cardio-oncology, this is kind of where my mind was and where I was thinking about what what I would see most of the time. And I think this is largely true. This is probably, the meat of cardio oncology. And I think it's also where the most data lives, just because these drugs have been around the longest. And so we've had the ability to collect data for a long amount of time. And today, this is not what I'm about to talk about. Instead, I'm going to talk about some of the newer things that are out there, and some of the developing things. So there's a lot of other, I think, what kind of falls into cardio oncology for us. And the ones that are highlighted here, the ones that are bold here, are what we're headed towards today. But a lot of different drugs out here, and a lot of different cardiotoxicities. And then, so androgen deprivation therapy, you got VEGF drugs, along with kind of this like alphabet soup of other drugs that are out there, all with specific cardiotoxicities. And it becomes, frankly, a little tedious to kind of keep up with everything and what should be done, which is why that consensus statement, or that guideline document from the ESC, was really helpful 2 years ago. And then finally, like I said, this clonal hematopoiesis of indeterminate potential, or CHIP, fits kind of adjacent to cardio oncology, which I'll share with you today. So a few quick hits. So I've got these like kind of 3 cases that we're going to go through that I think will be meaningful, and it's what we see commonly in our clinics. And then we'll transition to kind of what I do in the lab. So for just to get us started off, we have a patient case with a 77-year-old male. He's got a recent diagnosis of metastatic prostate cancer, and his oncologist started leuprolide and abiraterone about 6 months ago. He's had an event already. He's had an STEMI, he had a stent. He's also got diabetes, hypertension, hyperlipidemia. You can read his meds here. It's unclear to me how he got onto pravastatin 40, but alas. We've got some work to do on his blood pressure. His BMI is above normal. He's got a normal ECG. His LDL is a little high. He's had an echo recently with no big concerns there. He's, despite constant counseling, he is still smoking about a pack a day, and is not exactly following what we recommend in terms of lifestyle. And so perhaps you remember, as I've often tried to forget or hope that I would never see again after my medical boards, but this is the hypothalamic and pituitary axis, and you've got the hormones that the gonadotropin releasing hormones that travel between hypothalamus and the pituitary, then acting on the sex hormones, or the sex organs, to then, in this case, lead to the promotion of prostate cancer progression. And we've known for some time that inhibiting this axis here increases the survival of prostate cancer patients. And then more recently, this is like data that came from 2017 or so, these CYP17 inhibitors with abiraterone can also augment the benefit of GnRH antagonist or agonists. And we've seen that in a little bit of data here from the New England Journal, where ADT alone is inferior to that plus abiraterone. And so this is actually what the majority of the patients that come through our clinic are on. And these patients, about 50% of them will get put on a regimen like this. And there are about 100,000, between 250 and 300,000 prostate cancer patients a year. And so somewhere between 100 and 200,000 patients will be on these drugs that have a higher risk for cardiovascular events. And so what are those risks? This was a study that came out in 2006, so a little bit an older study, but it was a lot of patients, so I think we put a little bit more stock in it. These are Medicare patients. These patients had localized prostate cancer, so non-metastatic disease, and a proportion of them got a GnRH agonist, and a proportion of them underwent just total or a bilateral orchiectomy. And you can see down here the take-home points are that these patients, especially the ones that are on the GnRH agonists, are at a higher risk for the things that you read here. So incident diabetes, coronary heart disease, MIs, and then sudden cardiac death. And these numbers kind of put more simply, this is a 44% increase for incident diabetes, or 15% or 16% increase in incident coronary disease. And so these are the things that we're thinking about in terms of what we're trying to prepare for or prevent when we see a patient like the one that I just shared with you in clinic. And I would actually say that the average patient that comes in the clinic asking for a consultation for starting ADT or ADT with abiraterone is more of a primary prevention scenario. And so when I see these patients, I try to think, what levers do we have to pull on to maximally give us maximal prevention in the next coming months to try to get them from where they are now through the end of their treatment without an event. And this slide I put on here, not because I'm going to plan to fully discuss, but to put up as a demonstration of kind of how little we know about why this happens. And so there's a lot of different proposed mechanisms out there for why inhibiting the HPA axis, inhibiting testosterone causes cardiac events, MIs, sudden cardiac death. And I think it's fairly safe to say that the jury is still out here. Couldn't find a good example of a singular mechanism that seems to fully explain this. And so I think, to kind of sum up ADT in whole, is that there's a lot of complicated biology going on there. And luckily, I don't have to directly address that in my clinic. But this is a relatively clinically uncomplicated scenario. And the thing to remember about these patients is that during their treatment, they're going to be at higher risk for those things that I shared. And then how do we maximally prevent those things from occurring? And so in our patient's case, we had a lot of things we needed to work on. He was on a moderate or low intensity statin. We had to work on his blood pressure. We needed to work on his lifestyle. And we certainly needed to stop him from smoking because that's going to put him, pound for pound at the greatest risk for some sort of event. And so then what do we do with these patients? We're, like I said, initially risk stratifying them. We're getting an ECG and we're caring for them, providing, world-class care like you guys do here, based on their risk profile, knowing that getting ADT is going to put them at higher risk across all those categories. And so these patients, like I said, usually come to me in a primary prevention scenario. And we've got a few of our prostate docs that I swear in their order sets is a refer to cardio-oncology order every time they put this in, which is great for us to see these patients. I would say that the asterisk here is to remember to discuss the possibility of recommending not giving a therapy. And I don't know that actually ever occurs here, because one of the questions we get a lot in cardio-oncology is, hey doc, we've had this complication. Is it time to stop this therapy, or do we need to go a different direction? And I would say, at least in my experience, in my partner's experience, we've never actually not recommended ADT in this scenario. And so this is not one of those things where we try to put our foot down or throw our weight around in terms of saying, well, we think that this is going to put your patient at too high of a risk from a cardiovascular standpoint. This is much more of we will work with you to maximally enable your patient to receive the therapy that they need. And then kind of this underlying theme, I think that is across, all or most of cardio-oncology is really this kind of prevention and risk stratification mindset is really kind of foundational to cardio-oncology. So switching from that into the tyrosine kinase inhibitors, this is where we're getting into this kind of word salad of drug names, which I feel like is sometimes the sum total of what I do is looking up drugs in my clinic and figuring out what they are and what they do. But the case here, so this is a 73-year-old woman. She's had, B-cell leukemia, and she's being referred because she's kind of being considered for this new CAR T-cell therapy. But her history is interesting, and I think demonstrative of the patients that come through our clinic. She had induction therapy kind of with some of the older drugs that aren't really being discussed today. And then they switched to these next generation, these TKIs or tyrosine kinase inhibitors with imatinib, and perhaps you guys are maybe most familiar with that one. That's Gleevec. And then kind of through a whole series of drugs that are second and third generation TKIs. And you can see that she had a hard time with these medications. She had a possible TIA, she had hypertension, she had effusions. When she gets to us, she's on this ponatinib. And she's managed to make it through all of this actually without ever seeing us. And so I think is also kind of demonstrative of how we're still working with our oncologists to say, hey, when you start a new drug is the time to reach out rather than waiting for a complication to occur and then to reach out. And so as a way of introduction, like I said, tyrosine kinase inhibitors really changed the face of treatment for CML and for some of these cancers that were previously kind of a death sentence. And that one really being Gleevec is the major one. The ESC has a really great series of charts that all kind of look like this. And I promise you, we're not going to hit every point here, but I think the point in sharing these is actually to show that ESC document for when you're in the clinic. You can pull one of these up, you can find the drug that your patient's on, and you can pretty easily see the things that you're going to need to worry about. But you can see, our patient was on several of these drugs, and indeed, did have some of these complications that you see here. And just for everybody, these are like non-standard atrial fibrillation, heart failure. This is dyslipidemia. This is high glucose, pericardial effusion, pleural effusion, pulmonary hypertension, and vascular toxicity. And then our patient, as she came in, was on ponatinib down here, which you can see is kind of the worst offender of all of the TKIs across all of these categories, with the most common thing being experienced is hypertension. And essentially the TKIs cause their problem because of this unfolded protein response, something that we're not really going to dig down on, but the toxicity is directly acting on whatever cell it is. And a lot of times it tends to be dividing cells. In this case, a lot of these are endothelial type derived problems. So that's where like kind of the hypertension story comes in there. And so along with those kind of complication charts in that ESC is also this follow-up protocol kind of set of diagrams from that document. And so you can see the drug names here and kind of the follow-up strategy. And we're not going to like hit every one of these. Like I said, this is more just to show that the framework is out there for making clinical decisions based on patient, their disease, and their treatment. And so this is super valuable in our clinic in terms of trying to come up with treatment plans or just coming up with the way that the mental framework for the way we think about this. Because you can imagine before this, kind of coming through fellowship, we had not really much of this at all. And we had to kind of think about and de novo come up with screening and monitoring strategies for our patients that were coming in with these new drugs that we had only read about in the research literature. One other thing I wanted to mention before we kind of pivot out of the TKIs was that, of course, it gets a little bit more complicated, and that TKIs are not just for CML. They're for a variety of things. There's a whole other, kind of set of drugs that are also TKIs, but aimed at VEGF. And the big complication with VEGF inhibition is hypertension. And I would say that this is a class-defining side effect. I have not had a single patient that has went on one of these drugs and not had hypertension. And so this effect usually happens actually hours or at least days from taking the drug, and is dose dependent and is almost 100% reversible upon discontinuation of taking a VEGF inhibitor. And I think the take-home point here, just for VEGFs specifically, is to be thinking about being one step ahead of the VEGF treatment. So if they get to you and they're already have hypertension in clinic and they've already taken the drug, it's one set of scenarios. If they're normotensive and they're about to take the drug in clinic, it's kind of a different set of scenarios. And then concomitantly, to be thinking about what happens when they stop and to provide really good education in those areas, because when they stop, their blood pressure will retreat. And if they don't adjust their medications, they will have problems. And so having that dialogue with the patient on the day that they're in your clinic or on the day that they follow up with you, and having the ability to have at-home blood pressure monitoring in this case is really kind of key to, I think, a successful transition both on and off of these VEGF TKIs. And so to sum up here, the TKIs, this is going back to our case, what I would do for this lady that's on ponatinib, and this is the BCR-ABL TKI, not the VEGF TKI, but she needs lipids and an A1C today. She also needed to get an echo. And for ponatinib, and perhaps you saw it across there, is actually one of the ones that causes vascular toxicity. So you get ABIs, and we'll see her again in 3 months. And she has since done well without any new complications of this therapy, which is encouraging. So she can continue to get the care that she needs. She'll continue to see me, and hopefully we'll go on our merry ways. And so a couple of points to remember. So if you see the word, TNIB, the TI in there is for tyrosine kinase inhibitor. And depending on what comes before it is where it's acting. But any word like that should key you into this is perhaps something that we should think about in a kind of forward-thinking manner and be acting now rather than later on what we might do with this. And just a reminder that the TKIs kind of have class and drug-specific effects. And then the theme here for cardio-oncology is that follow-up and the repeat testing is critical for ongoing care of your patients. And so we see patients kind of in short bursts, every 3 months for a year, because that's how long their treatment lasts, versus maybe seeing them again in 1 year and kind of having this more extended follow-up. So somewhere that's kind of somewhat more exciting. This is going to be more of an inpatient focused talk about immune checkpoint inhibitors. I'm not sure. I haven't actually talked to Hugo to see if there've been any cases here of ICI myocarditis. Should have asked about your experience last night. But this case that I'm going to share, I'm sure is probably congruent with some of the cases that y'all have had here. And so this is somewhat more aimed at inpatient care or critical care. And I think is a really important kind of thought to be having in your mind when you see patients with myocarditis. So this patient here was not mine. This actually took this is the index case at Vanderbilt, which was written up back in 2016. So this is a 63-year-old woman. She had metastatic melanoma, and she came in with chest pain and shortness of breath. She'd been on ipilimumab and nivolumab. So this is a CTLA-4 inhibitor, and this is a PD-1 inhibitor, and we'll talk just a little bit about those things. And then kind of in short succession later, she developed these symptoms. She kind of persisted at home for a couple of days, and then she came to the emergency department. And really not bearing a lead here, but this is her timeline of what happened to her. So she got to 10 days, she started being symptomatic. She then was admitted, and then we started trending her troponin levels. And you can see that very quickly this became a very serious situation and led to her ultimate demise only a few days later. And so she actually had a normal EKG when she came in, which then progressed to third-degree heart block, and then she had VT that she couldn't be resuscitated from, which was the circumstances surrounding her death. And I'd say that most of these occur. You can see this happened really within 2 weeks, and that's the case for most of these therapies. And myocarditis is one of a few of cardiovascular complications. If you've ever dealt with these in any other realm, and I saw some of these patients coming through my medicine residency, and really can be kind of pretty stark presentations of various autoimmune diseases kind of body-wide. And so these are some more of this patient's data. This was this complete heart block coming in, and then VT. And then I don't look at histology a lot personally, but or at least not with my own eyes, but you can see the normal histology here, kind of this smooth heart muscle here. And then compare and contrast that with this really massive infiltration of lymphocytes that you can see are mostly CD3 positive T cells. And this was really stark to me, seeing this patient in their fast progression, and looking at this under in histology maybe gives context to that really rapid decline. And so a little bit of science. This is how the PD-1s work. So you've got your tumor cell here, you've got your T cell here, and you've got your, it's not showing up, sorry. I thought it showed me there. And you've got this antigen that's telling your T cell, hey, this might be something you want to look into for destruction. And then in the case of cells that are from your body, you have this signal PD-L1 that says, hey, no, don't kill me. I'm actually yourself. And so that's one of the ways that cancer uses your immune system to try to evade destruction. And when we block that, as you can see on the right side, it disinhibits the T cell from performing its T cell duties, and the T cell can go on to destroy the tumor cell. And you can imagine that this is what happens in your heart when you have that T cell infiltration, and essentially your immune system is unleashed on some of your native tissues, causing that presentation that we saw in this case. And so going back again, like I said, to these ESC guidelines, I think are really great, because before we were just kind of feeling around in the dark and kind of calling people and saying, hey, what do you do with these patients when you see them? What do you do after you just crush them with steroids? And so the ESC has this great kind of flow chart here of how to think through some of this, and we can just kind of walk through it. And so you have a patient that we think they have a definitive diagnosis up here, which the definitive diagnosis is with, or I guess the gold standard is with, right heart biopsy. A lot of times especially in the acute period, we're working with the presumption of ICI myocarditis and not a definitive diagnosis. We attempt to do this with cardiac MRI, looking for late gadolinium enhancement, especially septal late GAD enhancement, seems to be the most specific. And in the absence of another possible myocarditis or ACS for presentations like this, common things are common. So it's good to kind of keep your head on a swivel when you see really sick patients, and not to anchor too much. But in the setting of somebody that's received any sort of immune checkpoint inhibitor in the last, really it's kind of 12 weeks is the period of time that we think about most cases occurring. This is kind of where your mind should go. Of course, you want to discontinue the drug, and you're going to admit them, and then you're going to give them a really whopping dose of methylpred for at least 3 days. And then from there, they're going to fall into one of these 3 categories. They're either, and this is going to make itself clear probably even before 3 days, but they're either going to be improving, in which case you can start, weaning and thinking about orals the way that you would normally do or give care. But really what I want to talk about is either the steroid refractory or this fulminant case, much like the one we had, which then entails admitting to the ICU and giving kind of ICU level care, and then reassessing, giving mechanical support if needed, and then also the second line of immunosuppression. So I think this is the piece of data that perhaps would be the most valuable in this case. So looking at the other drugs that are out there, there's kind of a whole kind of, this is like the list of things that have been tried. And I'll share a little bit of data. It looks like the mycophenolate mofetil, or MMF, has probably the most sum total amount of data. And I would say that the outcomes there are improved, but it's certainly not a panacea. The one that we tend to be excited about is abatacept, which is this CTLA-4 agonist. And in the case of our patient, we had she was on ipilimumab, which is a CTLA-4 antagonist. And for whatever reason, that seems to really tilt the scales towards having myocarditis, those 2 drugs together. And so in a case series, this is a paper put together by Joe S.C. Salem, and they did a case series of about 75 patients with ICI myocarditis. In the first 15, they did standard of care treatment with steroids alone. And of those, 60% ended up dying. And then the latter 50 or so patients, they had a new protocol where they added abatacept after steroids became refractory. And they had a mortality rate of about between 3 and 4% among those next 50 patients. And so there wasn't enough evidence for it to make it into the guidelines in this round, but I think that a more firm recommendation on second-line therapies and fulminant myocarditis are in the pipeline, which is an exciting state of affairs. And I'm actually relatively disappointed to say that, us at Vanderbilt, even despite being the place where some of these index cases were discovered and some of the research has been done, and indeed even the epitope for ICI myocarditis itself, was recently reported on out of our institution, that our institution has not been able to come to an agreement on how or when to treat these patients with fulminant myocarditis for a second-line therapy. And this specifically has to do with the cost of abatacept. We've had a really hard time getting our, the pharmacists are on board, but it's the people that are one level above us and the pharmacists to really get on board for, to say that this is what these patients need in these kind of dire moments. Once again, the SE kind of comes through in terms of what we want to do in terms of monitoring. And this is, again, up here just to be kind of demonstrative rather than something specific. And this is more of like a clinic based. This is, hey, we're going to start this. We think this patient's at increased risk. What should your next move be? And so the SC has a great resource in providing those kind of next steps. Okay, so to sum this up, we're going to rule out the alternatives, but we're going to have a really low threshold to start steroids. I feel like that's pretty standard. And then the secondary immunosuppression is, I think, is really going to give us a lot of other options and lots of patients to find improvement with those. And then the CMRI note, we try to use that if we can. Not many of our patients, I would say, at least in my experience, have been stable enough to visit the cardiac MRI. And so this is a little bit of, nice to have, but not necessarily required in the right context. Okay, so pivoting from what I do in the clinic to what I do in the research lab, and this has been a really exciting area of inquiry for me, and I think kind of interdigitates with I think personalized medicine with cardiovascular genomics and prevention. And so this is really exciting. And I've got a case to go along with it. So we've got a 64-year-old male. He's got secondary polycythemia, hypogonadism, hypertension, prediabetes, and he gets sent over to me from one of our partners over in oncology. Said, hey, would you take a look at this guy for me? So this gentleman, he'd been on testosterone for several years, and he had high hematocrits, and everybody thought that he had high hematocrits because of that. But at some point, and then they were actually doing intermittent phlebotomy for this. And at some point, his doc was like, hey, this doesn't seem right. You seem to have hematocrits that are elevated beyond what we would expect. And so we actually they actually sequenced him because they thought they were worried about maybe like a JAK2 mutation. And it turned out he didn't have a JAK2 mutation, but he had these two other mutations, DNMT3A and TET2. And these percentages here, I'll explain here in just a minute. But this was the context for which he was referred over to my clinic. And I'll let you mostly read this, but this is relatively kind of benign history and physical exam. He was an exerciser, never smoker. He was on, the medications you might expect. Nothing to write home about his physical exam, and not perfect blood pressure, but kind of within range. And so to summarize, he had these kind of medical history. He came in. When we talked to him, he didn't really have that many symptoms. He said, I remember being short of breath this one time, right after giving blood, and I stood up, felt short of breath, sat back down, felt better, and that's really all I can remember. And I was like, okay. And so he's in my clinic, he's got these quote high risk CHIP mutations. And so what is CHIP and what might make these mutations high risk? And, what level of cardiovascular risk specifically, is this putting him, at risk for? So CHIP, or clonal hematopoiesis of indeterminate potential, are acquired mutations in the bone marrow. So these are your bone marrow progenitor cells that create all of your other blood cells. And you can acquire these mutations here seen in that blue cell that then lead to a proliferative advantage, and they clonally expand, but they don't cause cancer. So this is somewhere halfway between normal and cancer. And so as you might imagine, if you've got this mutation, then it actually does put you at a higher risk of getting cancer. This is data that we put together from the UKB, which is a large biobank based in the UK. And yeah, sure enough, you do have a high risk of incident myeloid cancer. But if you actually go and look at the cause of death for these patients, the cause of death is actually more highly or much more cardiovascular than it is hematological. And so This is what has piqued my interest for the last 3 years, and the primary thing that I study in the research lab, and is trying to figure out why these patients are at higher risk of cardiovascular disease. And I think this is important because these are patients that are in my clinic. These are the patients that hang around in cardiology clinic in general. And this is, 15 to 15% prevalence in patients around age 70. And I think as our population ages, this only becomes more so. And so to give an example of what this looks like kind of where I practice, I actually recruited patients out of our cath lab. We recruited about 2,000 people. And essentially, if you had 2 feet inside of our cath lab, we said, come on, you can be in our study. We ended up being able to sequence, which is how you find a CHIP mutation, you sequence their blood. And then we were able to pair that sequencing up with coronary angiograms that we had from their visit to us. And so this is the data from that. These are a list of driver mutations. These are CHIP, or clonal hematopoiesis, is really a collection of several different mutations that tend to cause myeloid cancers. Like I said, patients that have CHIP mutations don't have cancer. And they're also typically asymptomatic at the time where they initiate their, or at the time of their mutation occurs. So this is a normal distribution of what we think of having CHIP mutations. These, you can see DNMT3A and TET2 are the 2 mutations that our patient had. And they are indeed the 2 most common mutations. I think the 2 most interesting mutations as well, as you'll see here in just a minute. And so this is what we would tend to see that lines up with what happens kind of at the population level. But where this gets interesting is that CHIP, where a patient having one of those mutations, is actually much higher prevalence in our cath lab than it is in a normal healthy population. And so knowing that this is correlated with cardiovascular disease, perhaps not all that surprising that, querying a group of patients in the path lab would be enriched for this. But I think thinking about this in the reverse would be that if you could know this on the front end, would you treat this patient any differently, knowing they're at higher risk for a number of cardiovascular diseases? Which is kind of the question that I think about a lot. And so we weren't able to really pull that much data from our EHR because it's the way it's all put together, but we were able to discern, why these patients were being referred to the cath lab in the first place. And I put this up here mostly just for interest sake. I don't know that I would take any of this to the bank, but I do think it's interesting that dyspnea signal. So patients with CHIP tend to be referred for shortness of breath more often than their non-CHIP counterparts. And our patient that we had in the clinic, that's the only thing he said to me. He's like, hey, I was short of breath once. Not that I would necessarily, send him to go get a cath based on that history. I just find that interesting. And since we published this, there's been a paper that's come out that has actually correlated the presence of CHIP with HFpEF. And so that gets me thinking about this dyspnea signal some more too. But getting to the meat of it, so their CHIP status is really associated with left main disease. And so you can see here that in the controls, kind of in the middle there, CHIP to the right, we've got these measures of either any stenosis and then the territory, so left main, left anterior descending, circumflex, and RCA. And you can see the proportions there on each side, control and CHIP. And if you've got a CHIP mutation, you have a much higher risk of having left main disease. So almost more than 1 in 4 patients that walk into the cath lab are at risk of having a left main disease if you have CHIP mutation. And breaking this down, so we then could look by types of mutations. So remember TET2, DNMT3A, the 2 most common. This is TET2, and I'm really interested in TET2 because TET2 seems to have more severe cardiovascular disease than the other one. And so this is really what drove that signal. And looking at this, and the numbers are thin here, admittedly, 42 patients with TET2, but of those, 15 or 35% had left main disease, or 81% had any stenosis. So I could tell you a priori, a patient walking into the cath lab has an 81% chance of having any stenosis, I would think that would be pretty valuable in terms of how I would treat and address somebody's care. And so this is kind of like what has me and has held my interest for a number of years now. And so to summarize this last kind of half of what I just shared. But this CHIP mutation, this is a risk factor for cardiovascular disease. It's really enriched in our cath lab. And that makes the cath lab a really ideal spot to try to recruit for studies that need to follow about this. You know, what happens when you find these patients resectively and do something about it? We don't know the answer to that. And then again, CHIP is correlated with angiographic left main stenosis, especially TET2 CHIP. And to return to our clinical case, because I think this is kind of where this gets interesting and drives this point home, we have our patient, his summary is here. He's got these two mutations, TET2 and DMT3A. And so then based on what we know now, you know, would we do anything different? Or what should we do? And we had a pretty low index of suspicion. This patient was very interested in his own care, and he was concerned about the CHIP mutations. And he had done some reading, which helps and hurts sometimes, as you guys know. And so we discussed kind of the options, and we decided for a more aggressive approach. We ended up getting a echocardiogram first, which was stone cold normal. And then we actually sent him to get a CT A of his coronaries. And you can see here, we were really surprised to find this guy who had no symptoms sitting in our clinic a couple of days before with this CADRADS4 result. And so you can see he had severe triple vessel disease. Interestingly enough, he actually didn't have real severe left main disease. So not everybody follows the data, but we were very shocked to kind of see this. And so now he's got triple vessel disease. He's sitting there. He's more or less asymptomatic. What do you do with him? You know, do you do nothing? Do you talk about it with some of your partners? And so this is what we did. We actually had a heart team meeting about him, and the surgeons ended up winning out here and took him for bypass grafting that same week. He's had a great outcome. I've continued to see him in clinic, and he's very thankful for kind of the approach we had. But this patient, I think, is interesting because he didn't really receive different care because of his mutations, but that was at least playing a part in our minds as we were making decisions about him. And I think that we, in the future, will have and find these patients long before they have severe disease. And so the question there is, when we do, how should we treat them? And should we treat them any differently than we do, somebody else? And so leading onto that, there's actually we are enrolling right now a clinical trial looking at these two mutations, TET2 and DNP3A, in patients with existing coronary disease. So they've had to have had an event. And this is testing two kind of anti-inflammatory markers two anti-inflammatory drugs, NLRP3 and IL-18. And we have enrolled our first patient just recently, and which is kind of an exciting prospect. And so the other kind of what I do in the lab is figuring out exactly how TET2 causes these things at a kind of cellular and molecular level. And that's kind of probably outside the scope of what we're going to talk about today, but certainly takes up a lot of my mind space and thought space and as a proportion of my week. So big summary here, some parting thoughts on cardio-oncology, just in general. And the first point there is data-free zones is basically where I live on the daily. And I think that this gives me a great ability to think critically and to perhaps not necessarily live and die by the guidelines and see a patient for what they are and try to coalesce my understanding and give them really good care. And I would say that the little kind of add on to that is don't be afraid to Google a drug name, because like I said, I feel like that's at least 25% of what I do on the daily. Communication and collaboration is key. I have a lot of oncologists' phone numbers. We text, we do the Epic chat deal. It's not perfect, but the communication is really vital to this. Hey, I've got a patient. Hey, what are you about to do with this? We have this new finding. His EF is lower. Are there other options for this patient? Are the kind of conversations that we have kind of in real time, and that have to happen in real time because these patients are moving fast, and we've got to be there when they need us. Prevention and risk factor modification are rife all through this, and the ESC is a great guideline, or has a great set of guidelines to kind of set up the framework there. And we aren't shy about seeing patients again. And we'll see you in 6 weeks. We'll see you in 3 weeks. We'll see you in 3 months. Are all reasonable. And then my personal kind of bias here is about CHIP and as it being an emerging risk factor for cardiovascular disease and how we will kind of navigate the cardiovascular genetics and preventative medicine alongside kind of this like personal medicine approach is a super exciting place to be. And so with that, I've got a lot of people to thank. I've got some collaborators kind of here, near and far. This is my wife, and we've since added, we've got a third one who's 5 months old. So my house is clean and quiet and nice, and I get good sleep. I have my laboratory here, which are a whole bunch of nerds. This is like a GWAS plot that we were dressed up as for Halloween. It's a little bit embarrassing. And then the Vanderbilt Physician Scientist Training Program has been a really great resource over the years. So with that, happy to take any questions.
All right, great discussion there, Brett. Really fascinating information and really seeing the overlap between the cardiovascular space and oncology, because I think sometimes people think of these as two very different fields, but clearly we can see there's a fair amount of overlap. Could you maybe talk a little bit about what we've learned about cardiovascular pathways or pathophysiology from what we've seen from the oncologic approach of directed therapy towards certain pathways and how that impacts cardiovascular outcomes?
Meaning from a clinical care standpoint, or from like you actually mean like science, like what?
A little bit of the science. So, for example, what do we know about VEGF inhibitors, and what is the pathway for VEGF and why that leads to hypertension and things like that?
Sure. Yeah. So part of that, at least for the TKIs, and especially the VEGF TKIs, is a direct vascular insult, and so this is really tilting you towards hypertension in a way. And for the TKIs, this is it actually causes mitochondrial dysfunction. And so the unfolded protein response that occurs leads to all these, you have like unfolded protein signaling receptor molecules that then signal down and then cause either autophagy or like programmed cell death in other ways that then contribute towards hypertension, especially in the setting of VEGF is one example.
Suzanne, do we have any questions online?
So the microphone isn't working, so if you have a question, just feel free to stand up and ask it.
See, Dr. P has a question.
Sorry.
You can stand up and ask.
Yeah, so great talk. We appreciate you coming and helping us understand. So I have several questions actually. Let's start with one which is the same context that we were asking. Let's say, for example, that we know that TKIs create hypertension. We have an idea in terms of what is the underlying pathophysiology. Does this lead us in selecting specific, for example, hypertensive medicines, for example, an ARB or a calcium channel blocker or a medication that works on the endothelium is more preferable? Do you have any understanding in terms of how to treat hypertension in these cases?
Yeah, no, that's a good question. And you would hope that those would follow on, right? That one would lead to the other. And to the best of my knowledge, there is not a significant difference in the way that we approach treating hypertension in the setting of VEGF versus your garden variety hypertension. And that's the way at least that's the way it's written in the ESC most recently. I don't know if part of the beauty of this is honestly getting to ask people, near and far about their own experiences and what works and what doesn't. I don't know if you have a particular experience with one or the other that seems to be preferable, because I'd love to know. Yeah.
I was going to say, for a while, the thought process was for some of these VEGF inhibitor patients that ACEs, ARB, and calcium channel blockers are sort of the preferred agents because there's some associated risk as well with nephropathy and proteinuria. Yeah. Has the field sort of moved away from that, or
no? Those are still top recommendations. Okay. Yeah.
All right. Any more questions?
Yeah, we can move on, I guess, if anybody. So a second question has to do with the testosterone inhibition pathway. So the cardiovascular outcomes using the testosterone inhibiting the testosterone pathway in prostate cancer patients, are they related to inhibiting the testosterone, or it is a different mechanism involved?
Yeah, I think there are hypotheses either way, that there are direct actions from the testosterone inhibition. I think more circumspect or maybe more suspect in my own mind are the follow-on from that, right? Is the diabetes and the not hypertension, but the kind of metabolic syndrome that happens as a result. And I don't think that the two have been disentangled completely. But my money would be on the metabolic syndrome.
The reason why I'm asking that is because we see a lot of males that they come with low or high level testosterone supplementation that they don't necessarily suffer from prostate cancer. And then they're asking in terms of recommendation, what to do next. So if inhibiting the testosterone creates cardiovascular outcomes, then maybe low level supplementation may not necessarily be a bad thing, although I know that a lot of people disagree with this approach, and I'll pass the mic to one of them.
And just to continue on this, in my clinic, so I do a lot of microvascular dysfunction and coronary spasm. I actually end up seeing a lot of women in perimenopausal age that are now getting testosterone supplementation. So what is the link with cardiovascular disease? What would you tell us about that?
Yeah, with cardiovascular disease and testosterone supplementation, I would say that in the past, I certainly maybe had these things incorrectly linked in my mind. And I think that has the root cause of that was the sex difference in the prevalence of cardiovascular disease. And I think I had ascribed a lot of the risk of cardiovascular disease in men being to testosterone. And I think it's actually a little bit the reverse. It might be the protective effect of estrogen. And so I think I personally had those kind of aligned in my own mind. But I don't know that I have any greater insight to give you at this particular moment regarding the risk of testosterone supplementation in cardiovascular disease, other than, or if that's even right, or if it could be a good approach. I mean, it seems almost sacrilege to say that, just based on some of the prevailing thoughts out there, but.
I'm going to ask one more question. I'm very intrigued by your research, specifically the chip. And the question is, did you link this to particular inflammatory markers that we can also follow up, or other species of, say, cholesterol like LP(a) or ApoB? Yeah, so the risk of these chip mutations occurs independent of LDL, and there's actually very little signal there for a confounder like smoking. Like, is this all just, do people that smoke get chip and they get cardiovascular disease? That connection has been worked out, and it looks like chip is an independent risk factor for various kinds of cardiovascular disease. The kind that I'm interested in is atherosclerotic disease. And it does look like I said, the other half of my research is really kind of digging down on what mechanisms at play here. And it is an inflammatory mechanism. And it looks like there is inappropriate activation of the NLRP3 inflammasome, which is kind of this big cellular construct that then is really good at putting out IL-1 beta and IL-6. And so the surrogate kind of, or what we think is probably the least common denominator here, the final common pathway, is probably IL-6. And so there's another company that's approached us to do a clinical trial with an IL-6 inhibitor that we hope to get into patients and see. And I think there's also an IL-6 trial in cardiovascular disease writ large, because we know that the inflammation in general interdigitates with the progression and initiation of atherosclerosis. And so I'm really excited to see the results of those trials.
And we do have a question that came in through the Zoom. If a cardiac MRI can be obtained, what are we expecting to see, and how would it change management?
Yeah, I think that's a really good question. And I think this is why our emphasis, at least at Vanderbilt, has not been to really force the cardiac MRI. And in the moments that this is leaning towards fulminant and being very severe, I'd say that the value add is not much. So we haven't put our efforts towards shipping people down to the cardiac MRI at some odd hour to have some bigger problem than we already have. The value add is confirming the diagnosis, but with enough kind of circumstantial evidence, we haven't mandated that, at least in our own practice. And so But again, septal late GAD enhancement is probably the single most specific in terms of the specific findings.
Thank you. Do we have any other questions or comments?
I was gonna,
Okay.
so Brett, I was gonna ask, so common medications we use, aspirin, statins that modify cardiovascular outcomes. Could you touch a bit on some of the data we have that actually showed us some of those medications do impact oncologic outcomes in terms of like a recurrence of cancers and things of that nature? Statins. Like, is there any data that showing with, for example, statins and, for example, patients with breast cancer undergoing treatment? I think there's some data that shows some lower recurrence rates of breast
That
cancer.
have statins on board.
Correct.
I'm not familiar with that data.
Yeah. So I think that, just to kind of make a few summary points, could you just touch on just a basic overview that each of us should leave here with for cancer patients as we see them in our clinic in that context?
Yeah, absolutely. So I think that the framework for which we should approach cancer patients in cardiovascular disease is really one of kind of that spans the 3 phases of care: before, during, and after. And I think that the more that patients can see us before, the better we're going to be able to carry them or help carry them through their cancer therapies. And as the therapies become increasingly complex, increasingly protracted, the ability for us to interdigitate with the oncologist is only going to be a benefit for the patient. And so, harkening back to that communication and collaboration, having a relationship with your local oncologist, I think, pays dividends in lots of ways. And so, not just for the camaraderie or for the kind of patients, but also just for patient care. And so that's like kind of a cornerstone of what we do. And I would say that the last thing I'd like to leave you with would be to just pay attention, to look at these drugs, especially the new drugs. There is a decent chance that you will see a new, or maybe even for the first time, cardiovascular complication of these drugs because of the way that they are approved and put out in the world. There is a non-zero chance that you guys will identify the next important cardiovascular complication of some of these drugs and then be able to share it with the rest of the world. And so don't be afraid to look up, that new funny sounding drug and try to put together a story for why your patient's presenting with cardiovascular disease at this particular moment.
All right, excellent. Thanks again, Brett. Really enlightening conversation. I'll just make a few comments while we're on the topic. Just keep in mind, we do have a cardio-oncology practice here at Georgia Heart, and we have a specific cardio-oncology consult in Epic. So for patients that do have these oncologic histories and undergoing chemo, we do see a fair amount of these patients referred to our clinic as we collaborate with our oncologists. So thanks again. We'll see you guys next time. Sure.